Welcome to Season 2 of Talk Lab to Me. Talk Lab to Me is an engaging discourse podcast hosted by COLA, a leading physician-directed accrediting organization that provides education and accreditation services to laboratories of all sizes. The podcast covers a wide range of topics, including the latest developments in laboratory science and medicine, as well as in-depth interviews with regulators and industry thought leaders about the importance of regulatory compliance. Welcome to Talk Lab to Me. I have the wonderful pleasure of welcoming back my co-host, COLA COO, Kathy Nusafora. Welcome to Talk Lab to Me again.
Thank you, Danny. It's great to be back on the podcast. Our distinguished guest today is Elizabeth Montgomery. Elizabeth is the National Vice President of Clinical Practice Innovation and Population Health at the National Kidney Foundation. In this role, she is responsible for the design, the dissemination, and implementation of the strategies articulated in CKD-Intercept, a multi-year, multi-pronged initiative to improve chronic kidney disease recognition in primary care. CKD-Intercept has demonstrated that it is possible to rapidly increase CKD testing, diagnosis, and management in integrated health systems, accountable care organizations, and safety net settings. The CKD-Intercept team is currently working to improve CKD care with 70 organizations nationally.
Also with us today is MJ Lewis. MJ is the National Kidney Foundation's Senior Project Director for the CKD-Intercept program.
It's an honor to be here. We're grateful for the conversation.
Well, thank you again, Elizabeth, for being here. So, Talk Lab to Me. Our first question is for you to tell our listeners at Talk Lab to Me a little bit about what drew you to the work in kidney health advocacy.
That actually is one of my favorite questions, because if you had said to me 15 years ago, I'd be having this conversation with you, I would have laughed at you. That I was a part of a group of people 15 years ago who were looking at why diagnosis fails. So the Society to Improve Diagnosis in Medicine. And I really didn't have kidney disease on my radar, except that there was a conversation that was orchestrated in 2014 at the Institute of Medicine regarding a publication that the society was trying to advance around diagnostic error. And as I was sitting in this presentation, a gentleman responsible for quality at Kaiser Permanente was presenting data about kidney disease and how 80% of people with undiagnosed CKD had laboratory evidence in their electronic health record, how rates of diagnosis and intervention were low, how this was a significant population of individuals who were at risk and not receiving care. And I sat in that room saying to myself, there's a solution for this. And about 2 weeks later, someone mentioned to me that the National Kidney Foundation was looking for someone to help them improve outcomes around kidney disease in primary care. And so I sent like a 7-page cover letter with 13 publications in to say, I think I might be able to help. And about 2.5 weeks later, I was working for the NKF at my first meeting with a strategic plan that was articulated within 12 weeks after that for the roadmap that now supports CKD-Intercept. And so it really was my background in diagnostic error and this question of why does this continue to happen when there are potential solutions out there, that brought me to the role and continue to support the work that we advance in terms of closing those gaps and actually improving outcomes.
Thank you for that background. So for the listeners who may be unfamiliar with the importance, can you walk us through the race-free eGFR equation and why the shift away from the race equation was so important for patients?
So another great question, because most people don't know that when they go to get a basic metabolic or comprehensive metabolic panel, that one of the tests included in that B or CMP is a kidney-related test, serum creatinine with EGFR. So if you consider kidney disease diagnosis, there are two tests that actually frame that diagnosis. One is serum creatinine with EGFR, and the second is urine albumin creatinine ratio. So serum creatinine with EGFR is one of the most frequently ordered tests in the United States. Why did we move in the direction of a race-free equation? So for many years, for a variety of reasons, previous equations that were employed to estimate kidney function included a race modifier, because the publication years ago that suggested that there could be a difference in terms of muscle mass based on racial considerations. Because we now understand that race is a social construct, not a biological construct, that ancestry, genetic ancestry, is much more complicated than the color of anyone's skins or the shape of their face or other, physical characteristics. We need to remove race from the conversation to ensure that everyone is treated equitably, and that this artificial modifier that increased EGFR outcomes for the Black community is eliminated. Again, because of all the genetic admixing that has occurred in the United States over the course of the last several hundred years, it was artificially increasing outcomes for a population where there was absolutely no scientific evidence to continue to support it. So we worked with the entire community, including the American Society of Nephrology, in a broad stakeholder group, to evaluate what really would be the most accurate and equitable approach to replacing old race-based equations. And the 2021 race-free CKD-EPI EGFR equation was the outcome of literally 2 years of investigation and consideration of 25 different potential solutions to arrive at the one that we have implemented since 2021. Why is that important to patients? Well, we need to ensure that everyone who has kidney disease is recognized in a timely manner. We need to ensure that everyone whose kidney disease is progressing has the data that most accurately and equitably reflects where they are in that progression paradigm. We need to ensure that when individuals are included on the deceased donor transplant wait list, that the equations that are employed to determine whether they belong on that wait list treat everyone equitably. So I'm happy to say that as a result of the work that we've done, looking specifically at transplant, that in 2024, we grabbed some data from the OPTN network, which kind of governs transplant in the United States. And their data suggested that as a result of this equation, there were 19,000 Black Americans who had their wait list status change as a result of the removal of this race modifier that artificially elevated their EGFR. And that of those individuals, 6,000 were transplanted because their status on the wait list had shifted after this artificial modifier was removed. So I would argue that there's a lot of patient impact that has occurred in terms of earlier diagnosis, earlier treatment, and absolutely access to life-saving transplant for a significant portion of people living with kidney disease.
Wow, what an impact. That is something you can be so proud of. I know we've got a long way to go yet. We've done surveys, we've read the data about, there are some laboratories that haven't converted to what I'm going to refer to, a term you introduced me to, a race-agnostic equation, which I think is a great term. But we know there are still some barriers out there. So what, from your experience, has been the single biggest challenge that laboratories have faced in implementing this race-agnostic equation? Is it LIS reprogramming? Is it reflex testing workflows? Is it reference intervals? What are the challenges? And how is the National Kidney Foundation actively working to resolve those barriers?
So really appreciate that question. And what I can say is that the National Kidney Foundation has literally had the privilege, and I mean privilege, of working with your organization and other organizations that are leaders in laboratory medicine nationally for almost 10 years. And so because we had a committed group of laboratory executives speaking with us on a regular basis, when we started advancing toward a recommendation, and we got an indication that the task force that was working on the removal of race from estimating GFR, we got the group working on how do we address these issues, so that when the new equation was advanced, there was a solution that was available to have everybody move forward rapidly. And so the team worked on publishing a paper, a clinical chemistry paper that was published just a couple of months, again, lightning speed for submission and approval. In terms of the question regarding validation and the changes that need to be made, and clearly articulating the equations that we wanted reprogrammed in the LIS. And what we saw, one of the most interesting parts of this was obtaining a new line code. How do you get a new line code for an equation that hasn't been published yet? But somehow or another, we managed to get that done, so that when this got published, and the switch was thrown and everyone knew there was a new equation coming, there was a recipe for change that was provided. The biggest challenge initially, in terms of the implementation of the equation in 2021, really was time. That there was limited pushback among the laboratory community about the need to make this happen. Race is, and an understanding that it is a social as opposed to a biological construct. So the challenges initially were associated with the LIS reprogramming, and some of the larger labs had 3,500 or more custom panels that had eGFR included in it, that all had to be reprogrammed, retested in order to ensure that needed to happen. And what we saw initially was, again, a lightning speed implementation. Within 2 years of announcing the race-free 2021 CKD-EPI equation as the solution, we had 60 or 65% of laboratories telling us that they had already implemented that equation. So now I think the hard work is happening. So we're somewhere between 65 and 70%, including the data that COLA has published with us on surveys that your organization has done, that suggests that there are other challenges we need to overcome. So for some laboratories, it could be that they are small, physician-owned, federally qualified, health center-based facilities that don't have the resources or necessarily the expertise to reprogram. We're looking to help you. The National Kidney Foundation has a program led by my colleague, MJ Lewis, who has been leading this initiative since she joined the organization. We have a program that we can help. We have mentors. We have access to some resources that can help drive the change if laboratories let us know that they are in a place where they're struggling with implementation. And then we have some equipment challenges that we have been bumping into, that where there are certain low volume analyzers, point of care devices that have the race-based equations baked into them and as part of their software. And we are trying to get our arms around what those equipment are. We have a list of maybe 10 instruments that we believe are contributing to the breakdowns in implementation, and ideally working with manufacturers to try to change this. But what we need to do is we need to hear from the community that we are still using race-based equations, so we can confirm what we understand to be the outcome around who those manufacturers are, and then work to drive a collective voice, because we're the National Kidney Foundation, we are not a client. So as many labs that are facing this issue of I'm using a low volume analyzer, I would love to have this change, we need you to align with us so that we can go collect and say the community is requiring that you change this, because not changing it has created a patient safety issue. So that's kind of where we are. We are actively working to identify labs. There are a couple of other strategies that I'll talk about later about how to figure out who those labs are that are still using race-based equations. But the challenge that we see right now are less of some of the challenges that you illustrated and more with the smaller labs implementation issue and the existing pre-programmed instruments.
So you've mentioned quite a few stakeholders, Elizabeth, that touches a lot of people: physicians, laboratory directors, health systems, patients, and I'm hearing manufacturers as well. So with all those moving parts, how do you prioritize where to start? Where do you go first?
If you think about the implementation of CKD Intercept, we started with labs. The laboratory work group was our first work group, because you all have the data that we need to address the gaps in care. So laboratory was at the table with us first, and laboratory helped inform what we refer to as our CKD data strategy, which allows us to look at any institution's electronic health record data to identify the rates of undertesting and underdiagnosis of kidney disease. However, to your point, lab alone is not changing this. So typically, what the National Kidney Foundation does is that we have an implementation model that leverages what's known as the collective impact model. And that means you get all the stakeholders in a room and you get them talking with each other about the common impacts of the problem that they have. And then you get them working together on recommendations. So the National Kidney Foundation employs this approach in all of the institutions where we are advancing change. Often it's our friends in laboratory medicine that help open the door for us. Often it's our friends in laboratory medicine that give us some data that we then can translate into a conversation with primary care and quality and chief of medicine, community health about, hey, you have a diagnostic stewardship and a patient safety challenge using your data to illustrate that. And then we bring them all into a conversation about how to find a common outcome. We don't typically bring equipment manufacturers into that discussion with us, but we do intend to bring the coalition of multiple voices that we have built through our implementation efforts to the manufacturers to get them to understand that there is collective impact that is being discussed here.
Elizabeth, I heard you mention about some of the challenges that smaller community hospitals may be facing. What are some examples of support that the National Kidney Foundation is currently or plan to give to these smaller community hospitals or even independent reference labs as they try to make this change? Because as we all know, the change can be costly and very time intensive, especially as for some labs are going through the workforce shortage and having a shortage of staff.
So that's a great question, Danny. And I think there's multiple levels to this. I think the first response I will provide is that we help organizations understand the institutional urgency to fix this problem. That if you're a rural hospital, a small hospital in a rural setting, you are dealing with a very diverse population. And so there are gaps in care that are associated with that. So that's first piece. Second piece is there's a business case here that the National Kidney Foundation has published data that illustrated that the implementation of basic, and I mean basic kidney disease care, the use of annual testing, regular diagnosis of laboratory evidence of kidney disease, and the use of ACEs and ARBs can reduce ER visits, hospitalizations, and readmissions as much as 30% upstream in stage 3 CKD. I can build you a business model that will illustrate what the impact will be on your institution in terms of potential cost aversion or improvements in value-based care around this implementation, which then helps justify why a laboratory leader might be able to really have a clear impact on the operations outcomes from both a clinical and financial perspective by advancing the implementation of the race-free equation, getting everyone on the same equation, and then leading the conversation regarding diagnostic stewardship to ensure that anyone who has laboratory evidence of kidney disease is diagnosed, appropriately diagnosed, because we published a paper, Project Santa Fe, that illustrated significant gaps in risk adjustments related to not having individuals diagnosed appropriately in value-based contracts. And then look at guideline concordant care and how the National Kidney Foundation can help implement that whole strategy if the institution is willing to work with us. So we start with building the business case. And then when we get to the conversation of, all right, literally, we are incredibly cash strapped. We don't have the ability to do that. As a result of our laboratory engagement work group, we have nationally recognized leaders who have worked in virtually every conceivable laboratory information system who have agreed to volunteer their time to help institutions walk this through. So, and then if that's not enough, as I mentioned earlier, we have some resources that we can bring to really smaller organizations that truly need external expertise to make that shift so that we can continue to drive this implementation. Did that adequately address your question, Danny?
It did, and I applaud you and the organization for exploring all these different avenues because this situation isn't isolated. It is directly patient safety, which makes it all of our issue. And with that said, I wonder with the potential of collaborations and help, you mentioned, those who are willing to volunteer their time, which is an amazing thing. What about the collaborations with laboratory information system manufacturers or health information exchange? Like I'm here in Maryland, so I think we have about 16 health information systems. So like something like Chris, what does that possibility for collaboration do to help promote this change?
Operationally speaking, let me just kind of go at the 30,000-foot level and work my way backwards. So I can say conclusively that large electronic health record vendors have implemented the availability of the 2021 race-free CKD-EPI equation in their electronic health records. That literally, I had a conversation with one of their chief medical officers last week. It is available. So the integration piece into clinical practice exists. when we think about the discussion of the implementation in the laboratory information systems themselves, if they're underneath these larger electronic health record systems, like for instance, Beaker is underneath Epic, then there's the consistency that exists there. The availability of the new equation in the software has never been presented to me as a limitation from a laboratory information systems perspective. So my understanding is that that isn't necessarily a barrier. What the barrier really is, in terms of how I understand what is going on, is the institution's decision to activate those equations, and the institution's decision to validate those equations in the panels and profiles that they offer as part of their deliverables, and that it's less of a software issue at this point. In 2021, it was definitely a software issue, but at this point, the equation has been normalized. It really is, are there other barriers now, such as the ability to do what needs to be done when I turn that switch on to reprogram all these custom panels or, whatever is associated with that. That really is the limitation today. Is that helpful?
That was very helpful, Elizabeth. Thank you. Now, as a laboratory scientist, I just think this is so exciting. And to all my laboratory science colleagues out there, just to recognize that we have the opportunity and, in fact, the obligation to join this cause. So how can laboratory science professionals out there, what can they do today, tomorrow, to help bridge that education gap within their own institutions? And what does that conversation look like when there is that resistance from their colleagues or from their leadership?
So from my perspective, and I'm sure my colleague MJ Lewis is now going to cringe, call MJ, that we are here to help. That is our function, right? Is to try to make this easier for you. We recognize, particularly if you're operating in a large integrated network, that there are a lot of people that have to say yes to make these changes. There are a lot of people that have to get into a conversation to determine whether or not you may have implemented the race-free EGFR in your core lab, but you may have analyzers in the emergency department or in oncology or in pre-surgical testing that are not sending samples to the core lab. They're processing on the facility to do an inventory of what that equipment looks like and whether or not race-based equations are being used there. We recognize there's lots of levels of approval that typically have to move forward. We've had those conversations in multiple organizations and are absolutely here to help facilitate them for you in your institution. We have business case we can provide to illustrate what the cost benefit would be for the institution to close the diagnostic stewardship gap. Conversations about the implications of having multiple EGFR equations in an institution when we're moving away from Cockcroft-Gault and into the use of the race-free CKD-EPI equation, that's a patient safety concern. So we have lots of arguments that we can offer. Join our laboratory engagement work group and participate in the conversations with the leaders that we convene on a regular basis that talk about these issues and are available to help you figure out what you can do within your institution to get over those barriers. And all of those things start with outreach to MJ Lewis.
Okay, MJ, thank you. So what messaging has proven to be the most effective when communicating the clinical equity significance of this change? I mean, we've heard so much about how we can get patients the treatment they need sooner. We know that it costs a lot of money to have advanced chronic kidney disease go untreated. We know that there's a relationship to cardiovascular disease. So many ways we can have impact. What messaging is the most effective?
So it's hard to say which one is most effective because there are a variety of different audiences that respond to a variety of different messages. For instance, I know in New York State, the first lawsuit has been filed from an anti-discrimination perspective around the ACA anti-discrimination clause for the use of a race-based equation. That first lawsuit has been filed. That's a message for compliance. When we think about the clinical consideration, one of the most powerful messages that laboratory leaders can convey around kidney disease is that more people with kidney disease will expire from a cardiovascular event than will ever see the inside of a dialysis center. So when we think about kidney disease, most organizations orient toward end stage and this really expensive perception of dialysis, which is in fact true. It is ridiculously expensive. However, when you consider the upstream population, which is orders of magnitude greater than the population that survives into end stage, and you consider the unmanaged cardiovascular risk in your population, you have an entirely different conversation to have. You have a conversation around HEDIS measures and performance incentives that can come from your health plan partners if you're operating in value-based contracts. You have a conversation about optimizing outcomes on diabetes and hypertension measures. If you look at the data regarding what's perceived as the percentage of people with diabetes or hypertension that are achieving articulated goals, they're never at 100%. And some part of that never being at 100% is because of the undiagnosed kidney disease that's eroding performance and management of diabetes and hypertension because medications aren't being employed or optimized to address their kidney function and its impact on clinical outcomes. That's another argument. I mentioned earlier the financial argument that there's data that ER visits, hospitalizations, and readmissions will be reduced by ensuring that people in this very high risk cohort are being managed effectively, even with basic tools to reduce that utilization that's associated with cardiovascular outcomes. So there's a conversation here. If you are an institution or associated with an institution that has a transplant center or has integrated nephrology, there is absolute benefit to your institution to implementing the race-free equation so that people are identified earlier, referred to nephrology in a timely manner to give you the opportunity to optimize care in nephrology before initiation of dialysis. And in the United States today, almost 50% of people who end up on dialysis only see a nephrologist to prepare for dialysis. Not an optimal outcome. And then if there's a transplant center, by ensuring that people are diagnosed using the race-free equation and have an opportunity for earlier referral, you get healthier people to your centers sooner, which creates opportunity for increase in growth in the number of transplants that you're actually affecting. So there are a variety of conversations that can be moved around this topic, depending on the audience that you're speaking to. Again, we speak this language in multiple dialects. So if you're interested in moving this forward in your institutions, have a conversation with us because we can help position you or we can help advance this with you in your institution if you think it would be helpful.
I would like to just share a personal story. Anyone that knows me knows I'm very close with my Nana grandmother. And as we have these discussions about kidney disease, I think about her because she's also living with kidney disease. And during her time, many tests that she was given was based on the race equation to determine, instead of the race-free equation that we later years some places have come to use. And I often find myself wondering, well, if that race-free equation was put in place before, could she have had a different outcome from where she is now? So when we sit here and we think of different things in our laboratory industry, we have to ask that question of why. It's okay to question the norm to make sure it's suiting the patients that we serve. I want to know, have you heard some impact stories of those who were historically affected by the race-based calculation? And what are some of these real-world differences that you hear?
So, Danny, I am sorry to hear that you even have that question because a family member is potentially affected by kidney disease. I am just saddened by that because it is, a significant burden on the family. And quite often when I present, any information regarding the work that we lead, we start with the patient story. And I raise the question, right? Doesn't matter, while there is disproportionate burden in communities of color, the experience is most people do not receive a diagnosis in a timely manner that allows them to address their lifestyle choices, be aware of what is going on, be empowered to take care of their health. And that in and of itself transcends the equation. So I mentioned earlier that we can conclusively say that a significant number of Americans who are eligible for transplant had their lives changed in a positive way as a result of removing the race modifier and everything that followed behind it, right? We have a bigger challenge than the race modifier in the new equation in order to answer your question. Yes, it is true that more people from Black communities will have evidence of kidney disease earlier because that modifier has been removed, but it still requires that they get a diagnosis. And the latest data that we have illustrates that as many as 87% of people with laboratory evidence of kidney disease remain undiagnosed in primary care. You take that a step further and consider the fact, and I mentioned earlier, that urine albumin creatinine ratio is the second test associated with the diagnosis of kidney disease. The majority of Americans who are at risk for kidney disease are not receiving urine albumin creatinine ratio testing annually. Why is that important? 60% of people who have impaired kidney function have albuminuria and a preserved EGFR. So not having that test administered on a regular, consistent way to identify early indications of kidney disease absolutely limits any ability to get in upstream. So you have the breakdown in general testing, you have the breakdown in clinicians' recognition and engagement around kidney disease, as well as this formally modified equation that elevated the outcomes for the Black community, which we have changed, but we're still working on this bigger problem. And this is the diagnostic stewardship comment that I meant earlier about laboratories have this information. You know who's not tested. You know who have laboratory evidence of kidney disease. This is truly an opportunity to get in and go, I won't even say the last mile, that there is a long run we have to get to ensure that all the work that we did to ensure that the EGFR equation is equitable actually translates into the care that your grandmother needed in order to get an early diagnosis and potentially mitigate progression over time. How did I do with that answer, Danny? Was that
excellent? Thank you
okay?
for sharing that. I think it's important for our listeners, whether they be laboratory science professional or those just having loved ones or themselves being affected, that we understand the impact that comes with this and the importance.
Yeah.
With that, as some of these laboratories that are making the transition or have made the transition, I can only imagine that came with a lot of downstream clinical decision making, changing in medication, as you mentioned, refers to nephrology, and also in transplant eligibility determination. Even when it came out or now, how are physicians being guided through those changes?
So as I mentioned earlier, the majority of people at risk for kidney disease are not receiving guideline concordant testing annually. The majority of individuals with laboratory evidence of kidney disease do not have a diagnosis for kidney disease in their electronic health record, which significantly impacts and raises the question for me for whether clinicians are actively titrating medication to kidney function as requested and required by many package inserts. Because most people are not identified early, referral to nephrology is suboptimal, with, as many as 40 to 50% of people crashing into dialysis annually with limited nephrology intervention and no upstream management to mitigate that progression. So I say all that to mean I would love to believe that the community unified around EGFR and the implementation of the race-free equation as a way to truly transform kidney disease care for the Black community and everyone else who's affected, but that has not been my experience. So in response to that, the National Kidney Foundation has a program called CKD-Intercept, where we literally partner directly with institutions to help them address this question. That we are now working, we're in 25 states with over 60 partners, actually 70 partners, as Kathy mentioned earlier, looking at how we can help them use their own electronic health record data to build the internal will to prioritize kidney. In the cardio kidney metabolic world, we call it elevating the K, to get the organizational buy-in on the importance of this work, and then recognizing that because leaders from across the institution need to be involved, if we want to create an intervention that can drive change, we need to bring them all together. Now, because this is a laboratory audience, you likely are familiar with the term Univance and the quality award that is focused on laboratory medicine, and recognizing multidisciplinary care that has impact and can be scalable. The National Kidney Foundation was recognized in 2025 with a Univance Award on the basis of this implementation model that I just described. We partnered with Sanford Health. We helped them look at their data. Once they realized that there was an opportunity for improvement, we convened a work work group. We got organizational buy-in. Sanford paid us to come and help them shape their intervention so that they could address the significant gaps in quality that they saw and did not want to tolerate. And as a result of that, we were able to, through this very collaborative approach, lead them through the design of an intervention that, when launched in December of 2023, raised their urine albumin creatinine ratio testing from 38% to 70% in 10 months. The rate of diagnosis among their cohort with diabetes went from 20% to 73% in 10 months. And there was a 5-fold increase in the use of SGLT2 inhibitors in that same 10-month period as a result of our collaboration. I just received 24-month outcomes from the Sanford team a couple of weeks ago. And the email, the subject line that came over with those outcomes was the word boom. So these changes were sustained over time because everyone, informatics, pathology, primary care, nephrology, community health, were all in a conversation about what needed to change, how it needed to change, and were unified behind the intervention that was developed and deployed across their institution. So that's what we can do together if you just reach out and let us know that you're interested and you'd like our help.
Wow, that's all I can say. Wow, that's amazing. Congratulations. I'm so glad that you brought up the urine albumin to creatinine ratio, because there's a little bit of confusion out there among the people who are used to a test that, in my opinion, is inappropriately named microalbumin. So why are these two tests sometimes confused? And what do you think laboratories should do to clarify the nomenclature for these tests?
Okay, another great, one of my favorite questions. So first and foremost, what laboratories can do to address the confusion here is to work with the National Kidney Foundation on a consensus statement to go back to your reagent suppliers to ensure that they rename the test in compliance with what the laboratory community is trying to advance. So anyone who wants to join that conversation, it will be a simple consensus statement. Let me know, because we need to address that because it is contributing to the confusion. We were on a conference call. That tells you how old I am. We were on a Zoom meeting earlier this week where one of our colleagues presented that a laboratory wouldn't implement the name urine albumin creatinine ratio because the reagents come over as microalbumin. So barrier number one we can work on. The confusion is an academic thing because they are the same test. It's just that urine albumin creatinine ratio describes the test accurately, as opposed to microalbumin, where I can't tell you where that name came from, and contributes to wide confusion in the ordering community. So there is a difference between the two tests. They are operationally the same. This is really a historical nomenclature perspective that is problematic. When the National Kidney Foundation, as I mentioned earlier, we convened the laboratory community in, let's say, 2016 to start the conversation about how we could work together to address laboratory barriers to kidney disease outcomes. Unifying behind the name urine albumin creatinine ratio with the tests reported as milligrams per gram was one of the concrete deliverables that all partners agreed to do. So operationally, I can say that the large national labs are all aligned here. Operationally, I can say that the large integrated systems that actively participate in our laboratory engagement work group are all aligned here. It's just other academic or other institutions that have academic pathology where we need to build some consensus, and then the smaller labs who may not be familiar or aware of the changes because they are smaller institutions and may not participate in every laboratory meeting, where we need to really kind of lead the charge and align with what the national community is articulating as potentially best for patients affected by kidney disease. So if you are working in an organization and there is any pushback on the implementation of renaming microalbumin to urine albumin creatinine ratio, I would just like to emphasize for you that urine albumin creatinine ratio, albuminuria in general, is one of the strongest risk predictors of cardiovascular events and mortality. So as we're advancing this understanding, and as I mentioned earlier, the significant population that has evidence of albuminuria with a preserved EGFR, where there is significantly elevated cardiovascular risk, but no momentum around addressing it, this is going to increase in the medical literature again and again and again as urine albumin creatinine ratio being that strong predictor for cardiovascular events. If you aren't communicating that to your ordering clinicians by not changing that name, making your lab compendium consistent with what is going on in the larger medical community around you, I would suggest that you're creating some patient safety issues that we need to mediate and we're willing to mitigate.
The urine albumin and the microalbumin are the same test, but if a physician orders the microalbumin, they're not going to get that all-important creatinine, which puts the albuminuria into perspective. So it would be a recommendation that we move the industry away from microalbumin entirely and just go to urine albumin to creatinine ratio.
So that was a great clarification, Kathy, and I'm really grateful for that because literally the National Kidney Foundation convened its laboratory engagement work group this week, and this discussion of whether or not we can eliminate the test for urine albumin was part of the conversation. Because we recognize that that contributes to the breakdown, and that by just offering the ratio and presenting it strictly as the ratio, we will be potentially addressing some of the gaps that exist here.
So Elizabeth, there's been some debate in the literature about whether cystatin C-based EGFR equation should be used more broadly alongside the other testing or instead of creatinine-based equations. So how is the National Kidney Foundation addressing the role of cystatin C in the new framework, and what are the practical barriers to broader cystatin C adoption in routine testing?
That is a really complex question, Kathy. So let me
I'm sorry.
No, it's all good. I appreciate it. But it is a complex question. So when the task force on the elimination of race from EGFR made their recommendations, they underscored the importance and value of cystatin C in the evaluation of kidney function. It is a much more stable and reliable biomarker than creatinine will ever be. Great that the recommendation was made. Operationally, its implementation is somewhat more problematic. So first challenge that we have to overcome is that there are 240 million basic metabolic panels or comprehensive metabolic panels that are ordered annually that currently include serum creatinine. So we can't simply replace creatinine with cystatin C, largely because not every laboratory offers cystatin C. Cystatin C is not necessarily calculated as quickly as creatinine is, and potentially could contribute to slowing down the analysis of the rest of the things that are included in the basic or comprehensive metabolic panel. And then you have a small issue associated with cost, where at present cystatin C is several orders of magnitude more expensive than a creatinine assay is. So while a better marker, there are some implementation challenges that are associated with it that we have been trying to work our way through as an organization. So for instance, one of the things that we have on our advocacy agenda is to work with CMS on a national coverage determination for cystatin C, so that we address the variability in reimbursement that presently exists around this test nationally. Because of the implementation issues, we have to recommend at the moment that cystatin C be used specifically in certain populations. So for instance, when we're thinking about when best to order cystatin C in a screening type of capacity, you're really looking for individuals who have extremes of muscle mass, so bodybuilders, amputees, or individuals with severe muscle wasting, or advanced age and frailty. So if you want to get a clearer picture of kidney health in older adults whose creatinine levels may falsely indicate better kidney function, cystatin C is a better choice for you. Individuals who are obese, who again fall under the extremes in body composition, and where you're really considering drugs that have a narrow therapeutic index, that you might want to consider ordering cystatin C as a reflex, and then recognizing that the most accurate assessment of kidney function beyond measured GFR is the combination of creatinine and cystatin C. So we advocate for the use of cystatin C when there are transitions, particularly in more advanced kidney disease, where you really want to ensure that you are reporting an accurate eGFR so you can get someone transplant waitlisted on the basis of the most accurate eGFR information you have. So while it's absolutely the stronger marker, those implementation challenges have limited the broad uptake. We know institutions that literally have had to eat over $1 million in excess testing because of cystatin C and it not being reimbursed by appropriately, at least from our perspective, by health plans. So we are moving in the direction of advancing this, but in the moment today, it is not as broadly available or as cost effective as creatinine is when you're thinking about particularly screening.
Well, that certainly clarifies it for me. Thank you, Elizabeth.
Sure.
So as we come down to the conclusion of our episode, I am so thankful to my co-host Kathy and Elizabeth for sharing your expertise and your thought. I have one last question. What is the single most important action you would ask every laboratory director, every laboratory science professional, QA, healthcare professional listening today to take? Whether it's an audit, a policy change, an educational initiative, that they can ensure that their institution is fully aligned with the current standard of care.
This is one of the most difficult questions you've raised today, because my response to that question would be anything. do anything. Start where you are, and any effort that you choose to advance will have an impact. Operationally speaking, if we're talking about the implementation of the race-free EGFR, the race-agnostic EGFR, if your core lab has implemented the 2021 equations, then doing the audit across your institution of other low volume analyzers would be the direction I would send you in first. Looking at just this implementation of the equation itself issue. And we know, I've seen data recently that it is possible to drive an institution to 99% use of the race agnostic equations. So we have data that illustrates that. And if it's helpful, we have an algorithm that can help you search your electronic health record data to not only identify if race-based equations are being employed, but where they're being employed to help track down who we need to speak to get that change to happen. So that audit, absolutely, for anyone who thinks they've already implemented in or knows they've implemented in their core lab and want to evaluate this bigger question of what else is going on with these patients. The second consideration is, all right, let's assume that you are the laboratory whose data I've looked at that says you are at 100% implementation of a race-free equations. Let's talk about diagnostic stewardship. And let's do a data strategy evaluation of the percentage of people who are at risk for kidney disease that are being tested annually for kidney disease to identify testing gaps that can be addressed. And then let's take a look at the percentage of individuals in the institution with laboratory evidence of kidney disease who do not have an ICD-10 code for CKD in their electronic health record. And believe it or not, having that ICD-10 code in the record has been demonstrated to change clinical behavior. There's lots of evidence behind that. If you are interested in policy changes, we can talk with you about what other organizations have done from a quality perspective around standing orders or engaging other members of a multidisciplinary care team to empower them to order the tests or highlight breakdowns in care. We can have that discussion with you. If you're interested in really demonstrating the diagnostic stewardship and this vision of illustrating the value of lab in a population health model, we absolutely can talk with you about how we've gotten 60 other organizations to drive change and how laboratory leadership can be with us at that table to really go all the way up to senior leadership to get change to happen and laboratory be recognized for all of the impact that it is in driving as a result of the improved care that comes from this process. If you'd simply like grand rounds, let us know, because we're glad to do that as well. So anything, you want to join our laboratory engagement work group, any step that you can take in the direction of ensuring that individuals in your institution who are at risk for or living with kidney disease are being treated equitably and are receiving quality care, we're all in. Just let us know how we can help.
Elizabeth, I've heard you mention several times the National Kidney Foundation can help, and you've mentioned your colleague, MJ Lewis, who has been very effective in leading this charge with you. How do our listeners reach out to the National Kidney Foundation or to MJ Lewis to say, hey, I want to get involved, or how can you help me?
Here's MJ's email. So it's mj.lewis, Lewis, at kidney, KIDNEY.org.
As we conclude this episode, I want to thank Kathy again, Elizabeth, and MJ. You should be getting a lot of information your way. So to our Talk Lab to Us listeners, MJ Lewis, she that was the email just provided, so she'll be able to answer those questions for you. Hopefully, you feel free to reach out with your questions or even just share what can I do and how can I start. So for now, until next time, stay compliant, stay curious, and keep talking lab to me.